Thank you.
Let me, of course, thank you also for this organizing the conference and the many inspiring talks. I was actually quite impressed with the first two talks. And let me actually continue the same line started already with Attila, with a specific focus on depression. So the topic when I choose was also specific in the sense that I am going to emphasize the relevance of health humanities based on a sensory process having probably an unquestionable importance in medicine. So that is the main focus of my talk, is on the complexity of pain perception. And this is general layout of the talk. So first, and really the first part of my talk, I would like to present evidences for a general call for necessity of health humanities in the understanding of pain perception. And later I will probably turn toward a more specific direction and will argue for a need in sensitivity to psychosocial conditions of pain patients. And of course, quite in line with that point, I will argue for a patient-centered communication. So the importance of patient-centered communication will be elaborated relatively extensively in the second part of my talk. And finally, the final part will include more methodological considerations. So I intend to present both qualitative, specifically artistic methods, and even quantitative methods inspired by or even related directly to health humanities. Yeah, and the very final point I have today is a brief summary of health humanities in multimodal pain management. So this is actually the layout. And let me start in. To ground my point, first let me just simply show the quite complex nature of pain perception. And of course, its many aspects relying quite heavily on humanistic considerations. I guess we all do probably agree with Goldberg, saying that pain is certainly the most common illness. And unfortunately, of course, as we know well, not just in an acute form, but also in a pathological, long-term, prolonged, that is, in a chronic form. And many models were born already to show the multidimensional nature or character of pain. And some of them, as for example, the one I'm presenting here, put a strong emphasis on suffering. Suffering as a feeling having quite elementary impact on pain reaction, pain behavior, the way how we are able to cope with the aversive nature of pain experience. And health humanities, I think, are certainly quite essential in understanding of the process, starting from a pure biological sensation, we say nociception, and ending somewhere in behavior, in pain behavior. The reason why health humanities definitely has an important role in this transition process is that that is also quite known, that multiple psychological, social cultural factors affect this transition from a pure physical sensation to, for example, the behavior and coping mechanisms with acute or even the chronic pain experiences. And well, this is perhaps just saying it in brackets, the relationship between the many personal and cultural factors and pain is definitely mutual. The double arrowheads aim to express the quite mutual relationship between a pain experience and many personal and cultural factors. So we can say, we can indicate the assumption strongly that pain may form a culture in many different respects. And well, honestly saying, I did not take too much risk with the topic of this talk, considering that as you may know, many specialists use journal papers, empirical findings, empirical studies were conducted and were addressed to the understanding of the pain paradox from the field of people working on health humanities. The pain paradox means that pain is supposed to be determined not, of course, just biological processes, but also, it's quite crucial point, to take the many social cultural factors, psychological processes, and the subjective nature of pain into account if we really want to get a deep insight in this complex and, of course, unquestionably important phenomenon in medicine. So health humanities, the relationship between health humanities and pain is not new. And the reason why the understanding of pain require, I think, not, of course, not just according to me, but require broader than simple biological reasoning is that pain experience, so feeling of pain, can be enhanced quite significantly by strategies, for example, those listed here. So both certain mental, cognitive, and behavior strategies can be resulted in a more intense and effectively a more aversive pain sensation. For example, the coping with pain may be highly dysfunctional and maladaptive when it is accompanied with a high level of catastrophizing attitude toward pain, when the patients report just too much fear, when they are just anxious about the underlying causes of the pain experience. And so this is just a list, right? The most important strategies we need to take into account if we really want to understand pain. And I think it already gives a clear indication what is written in the title of the slide, that definitely need to have a kind of humanistic view if we want to understand this complexity. But I would go a little bit further. And I mean, in addition to the list shown on the previous slide, let me also express the pain-related relevance of health and, of course, medical humanities, along with the well-known illustration of the epigenetic processes. I actually just borrowed the landscape symbolism of Weddington to show how the development of cognitive and behavior strategies toward pain may be influenced by many environmental factors represented here, symbolized here, by the variations in a hypothetical landscape. The next slide is going to be a bit more specific about the point I have. So then the rolling ball, right, in each of these two landscapes symbolizes the developmental process, which at a certain point may turn toward an adaptive direction and result in an adaptive, effective strategies toward pain. In contrast, however, it may also be the case, and actually many times that is the case, especially for patients having chronic pain symptoms, that the development of cognitive and behavior strategies will not just follow the adaptive route, but actually turn toward a maladaptive direction. At this point, the development of these cognitive strategies are just simply misdirected by many different influences coming from the social, cultural, and psychological environment. Ending in maladaptive strategies, ending in dysfunctional coping behavior against pain. And there are basically many different, indeed, there's a huge package of evidences we have that early life environment, and especially when it is aversive, unpredictable, and not just the early life, the childhood period in our life, but also the adulthood environment may contribute quite significantly to a maladaptive strategy against pain. So there are many evidences to show that high level of stress, and of course, even biological variations, even abnormal gene expressions due to psychosocial, cultural causes, And just again, let me emphasize that all of these effects will finally be resulted in a non-adaptive, dysfunctional strategy, behavior strategy against pain. Let me put this list into the context of health humanities. And again, probably everybody agrees in this forum that each of these listed effects belongs to the field of health humanities. And I think put a quite strong emphasis on a point, the first point what I want to emphasize in my talk, that the need of sensitivity to psychosocial conditions is basically unavoidable in therapies, clinical therapies of chronic or even acute pain patients. Yeah? So the need of sensitivity to psychosocial conditions is the first point. This is just a model about presented more like in a database way, that how traumatic experiences, be different beliefs, and adverse psychosocial conditions are significant risk factors of enhanced pain sensation experienced many times, much later, for example, in a late adult period. The model presented here aims to depict a hypothetical route between traumatic life events experienced during childhood and the pain experienced in future in adulthood. And the model, just again, I think, emphasizes that without having sensitivity to psychosocial circumstances, we miss actually pretty much. We miss many crucial information that may impact the outcome of pain therapies later. So it's just again, I think the sensitivity to psychosocial conditions of pain patients is quite crucial in the context of the therapies need to be selected, and of course need to be maximized in efficiency. This is just a model, and of course I know, without saying anything specific about the statistics shown on the arrows, this is just a model we tested in an earlier study to find links between early life conditions, as for example those I'm marking here, and the self-reported pain sensation, pain perception of in adulthood. And just again, without mentioning the statistical details, it seems to be that it's a quite clear finding that sensitivity to pain, so pain sensitivity reported by participants in adulthood, is influenced by a quite big package of factors consisting of many aversive past experiences regarding, for example, the socioeconomic status, regarding, for example, the unpredictability of life in childhood, and of course, family resources has been found to contribute to adult pain sensitivity quite significantly. I have also another slide. Well, it looks even more complex, but there's only one change in the slide. Now, the last dependent variable is not actually pain sensitivity. So it's not about how patients perceive the intensity of pain, but this is about catastrophization, a kind of affective character of pain, when we may tend to ruminate on it too much, when we may magnificate it, or sometimes we may feel ourselves a little bit helpless. So this is called pain catastrophization, and we found basically the same. We should draw the same identical conclusion as the one presented on the previous slide. So namely, individuals tend to catastrophize pain much more if they have a disadvantageous background, if they have unpredictable life environment, or with other words, when they were exposed to aversive psychosocial conditions much earlier, for example, during the childhood. And this is the second point I want to emphasize. So the first one, just to sum up, was that the sensitivity to psychosocial conditions of pain patients. It's definitely important and I think unavoidable. And the second point of mine is, especially based on the previous slides, showing that sensation of pain, experience with pain, subjective experience with pain is just so complex that it doesn't work without a quite strong influence, quite strong focus on the patient. Actually, there is, I think, a huge need of a patient-centered pain communication. So communication with pain patient has to be as patient-centered as possible. That's the second message I would like to emphasize today. And the first two talks already, I think, introduced different methods and mentioned, also brought many beautiful images. So in the next part of my slides, the talk will also be related more to the methodological considerations inspired by health humanities, showing, for example, a kind of potential method, potentially applicable method for patient-centered communication based on art projects. And so pain and visual art is my next point. This particular art project, actually, it's called Face-to-Face Project, was a goal to create a quite visible form of subjective pain experience. It was aimed to build up a new communication channel. It was aimed to open up a new communication channel based on visual art between the doctor and the pain patient. A bit more specifically, the method was that a set of photographic images or pain cards was used to explore whether they are useful to patients in healthcare consultations. Yeah, so the first images were created. I will show some example in the next slide. And then it was explored whether these images can be applicable in everyday clinical decision, in everyday discussions between a doctor and the patient. So that was quite practical aim was formed by this particular study. And the hypothesis was that images placed between the doctor and patient could remarkably improve communication. And well, these are just a few examples to show. And these were, by the way, created in the way that the artist had a quite long discussion with chronic pain patients. The artist had or made, we may say, deep interviews with chronic pain patients. And based on those interviews, she created these beautiful images, photographic images, or montage. Let me show a few more examples, including my favorite one in the middle. And yes, and there are two more here. These two were created specifically about migraines, chronic headaches. So these two images basically can be considered a visual interpretation of chronic headaches. And the point is that this art project became really successful. So our project really created a new communication channel about pain. It worked quite well. It actually improved the communication between the doctor and the patient. And as you can read in my second point, we can also generalize this improving effect of art and communication. Generally, well, we know that many evidences to show that visual art courses available in medical faculties can indeed facilitate the development of clinical observations and the understanding of the patient narratives. Yeah, and let me focus on the last term, the narrativity, the patient's narrative. Why patient's narrative is important. I have two answers for this question. The first answer just comes from my previous slides. Just comes from the fact that pain experience, the subjective pain experience, is just so extremely complex. So you cannot oversimplify it. You cannot over-formalize the clinical notes in respect of the symptoms reported by the patients. In addition to that, in addition to the complexity, the narrative of patients are also quite important, because there are basically quite clear observations that many patients, unfortunately, just reluctant to consider that his or her symptoms related to their own beliefs, their own thoughts, emotions, and may actually contribute biologically to the body production of pain. And unfortunately, such kind of patient narratives, so when a patient basically neglect or reject the psychosocial causes, potential psychosocial conditions behind his or her own pain experience, so such patient narratives might actively contribute the successfulness of the pain therapies. So that's why it's quite important to take into consideration. So just to sum up, many patients tend to reluctant to consider the non-biological factors and emphasizes more the somatic reasons behind pain experience. And I think it's we need to merge the question of why. So why do these patients just tend to be non-acceptive for the non-biological factors, potential non-biological factors behind their own pain? I think because on one hand, they may be worried too much about stigmatization. And on the other hand, they just want to hide some deep-rooted psychosocial causes behind the pain experience. So here's again a clear point where medical and health humanities can strengthen the communication between the doctor and the patient, inspiring much deeper discussions with the patients, in order to indicate more clearly what are the real causes behind, for example, a prolonged experience with pain. And the slide, what you are actually looking at, is again related to the methodological consideration. So the first method I wanted to share with you was a quite impressive, hope you also found it impressive, the quite impressive images created within a specific art project. And this one now goes more toward the direction of analytic methods. This is more about, the first two talks also introduced this question, the border between science and health humanities, whether it is sharp or not. The forthcoming few slides emphasize that perhaps the border between science and medical humanities is not necessarily so sharp. So there are bridges, and these bridges may be created by, for example, projects dedicated to the alliance of medical informatics and medical humanities. So the answer for the question presented in the title of this study is definitely no. So definitely it is not an unlikely alliance between medical humanities and medical informatics. Let me try to explain why I think that the answer for the question is no. I already mentioned a few slides ago that that might be a problem, that the current clinical notes we have about pain is just over-formalized, or formalized well. Of course, it contains quite precisely values of measurable variables. And of course, the clinical notes we have shows also the most important complaints reported by the patients, but usually nothing more. So information available in a regular clinical note does not really touch the points, the bullet points shown here. So it does not really provide information about what patients say and actually really feel. The patient's own report about distress, disability, potential regeneration, therapies are just unknown for the doctors relying on the regular clinical notes only. And the point here is that this may be an area where informatics, computational sciences, and medical humanities can reinforce each other quite effectively. One may, for example, argue that this kind of fusion, reinforcement between these two disciplines, informatics and humanities, may have essential contribution both to diagnostic and therapeutic way of thinking. And one may, first, let's drop again the question what I want to answer here. Is the field of health humanities ready to claim methods for the analysis of patients' subjective experience with pain? That's my question here. And one may say, why not? Why not, for example, inspire text analysis, medical text analysis, as an assessment of patients' self-narratives? Why don't we record patients' voice and analyze later with artificial intelligence methods, machine learning methods, in order to get more and more insight into the real feeling they have? The slide here just presents, of course, the many different data sets, basically quite frequently used in health data analysis, driven by artificial intelligence methods, laboratory results, medical imaging, clinical examination, and so on, regularly used to be analyzed by computer scientists. The suggestion of people working on health humanities, however, may be strong, that this list here has to be, why not, right? Has to be expanded further toward the reaction of patient's voice, own report about pain, verbal report, written reports can, I wouldn't say easily, but at least effectively analyzed by learning algorithms. And we have something at our hands. We have a kind of analytic methods, and we are able to contribute to everyday decision-making made, for example, by medical doctors treating chronic pain patients. And such methods, for example, can indeed provide clear-cut indications for pain management, pain therapies, and of course, pain education. And the very final part of my talk is just emphasize the importance of health humanities, this humanitic sensitivity in relation to pain management. The slide what you are now presented with shows just the most well-known methods available in non-pharmacological pain management. In brackets, you can read the multimodal pain therapy. This is actually a kind of gist about the multimodal approaches exist within the pain management. And of course, many of these non-pharmacological methods has, I think, direct link with health humanities. For example, music, art, drama therapies, expressive writing, and interventions. These are not just indirect connections. It's not; these are not just rely on attitudes strengthened by health humanities, but they are basically quite directly linked. And even if you consider pain therapies, which are not seem to be so much related to psychological conditions, social cultural background of the patients. So even if you consider a simple manual therapy, physical therapy against chronic pain, then I think we need to realize quite quickly, after looking at a model like this, that a physical therapist needs to be sensitive to social, psychosocial, and cultural background of the patient, because there are just so many shared decision makings between the patient and the therapist, preferences for the particular intervention from the patient and for a manual therapist, I think quite strongly related to a social way of thinking and the humanistic consideration, and will finally impact the outcome of the therapy quite significantly. Expectations, decisions, preferences, inseparable processes, mental processes, cultural processes from pain therapies, including even only physical therapy. And well, this is basically the end of my presentation, and just let me go back to the main points again. So then let me emphasize the points I had more from an education point of view. Health humanities in respect of pain deepens student knowledge and consideration about patients' perception of pain, and therefore, of course, it makes a student sensitive to psychosocial conditions. That was the first point I wanted to emphasize today. It opens opportunities, many different opportunities, for a patient-centered communication, which is probably one of the most important issues needs to be solved in pain management. And health humanities basically contribute both to the diagnostic and therapeutic considerations, and of course brings clinicians closer to the understanding of individualized pain coping strategies. And last but not the least, it's elementary to understand the complexity of pain. So it's elementary to understand affective, social, and cultural aspect of pain. And really the last is that we need to have a pain philosophy, which is definitely driven by partly health humanities. Thank you very much.